All right, good morning. Good morning, everyone, and welcome to the Texas HPV Coalition's annual HPV Vaccination Summit. We are on day 4. So if you've been hanging in with us throughout this week, thank you so much for your attendance, for joining. We've learned a great deal of information. We've had some amazing speakers, and it's just been an awesome time together. So thank you for joining. We are on our 4th and final day. It's Friday, and we're just really excited about the great speakers that we have today. I know that, again, if you've been hanging with us, you've had to go through this introduction each day, but I want to make sure that I do it just in case we have new faces who need a quick overview of the coalition and maybe just new to the work that we've done. So we're going to quickly get started with our introduction, and then we'll move forward. All right, so the Texas HPV Coalition focuses on the HPV vaccine as cancer prevention. This vaccine prevents 6 different types of cancers. It is safe and effective, and it is for both boys and girls, and our focus age group is between the ages of 9 and 12. During that age, it takes 2 doses. We do know that once a child reaches the age of 15 or older, it becomes a 3-dose series. Our mission with the HPV Coalition is to build collaboration, enhance communication, and work across Texas to increase HPV vaccination. We are able to do this work through our 4 different work groups, each of which you have heard from over this past week. We have our provider education work group, data and technology, systems improvement, and advocacy and awareness. So today we're going to hear from our data and technology work group. This work group is led by Dr. Jasmine Tiro and Dr. Sanjay Shite. A project that they have worked on and are still working on is a white paper that's entitled Improving Access and HPV Vaccination Data Here in Texas. We're really excited about where that white paper is going and excited to see what comes from it. We currently have 75 members on our roster. These members come from various types of organizations. As you can see here, we have many that are from academic research institutions, universities, nonprofit organizations, like the Immunization Partnership, the Department of State Health Services, local health departments, health systems, and more. So we really do have a great compilation of organizations that come together to do this work. Now, when we took some time out to kind of evaluate the engagement of our coalition, as you can see here, it's pretty even across the board. So between high, medium, low, and none, it's very similar. The numbers are very close. Our goal is to get those numbers leaning more towards the high to medium. We know the pandemic had a huge impact on the kind of work we were able to do, how often we were able to meet, and just our capacity, whether it was as a coalition or with our regular jobs. And so we are really excited about moving forward, starting with some new projects in 2022 and kind of hitting the ground running. In 2021, our goal was to reinvigorate the coalition. So we took some time to look at our goals, to work on our website, reevaluate commitment of members as well as work group leads, talk about our gaps, see how we can potentially fill those gaps. And as I stated, we're really excited about actually moving forward with that work in the upcoming year. We have over 40 organizations who work with us and are represented on the coalition. This slide just gives you a few of those that kind of predominate, those organizations that work with us the most. So as you can see, we have TMA, the Texas Pediatric Society, UT Southwestern, MD Anderson, the Immunization Partnership, I know UT Health. Those are some organizations that work with us and help us get the work done that we do within the coalition. If you are interested in getting more information, We will have a meeting on February the 10th at 10 a.m. That will be our very next full membership meeting. But if you would like additional information just from myself or my co-lead, Rachel Coughlin, we'd be happy to schedule some time to share with you some things that the coalition is doing. And hopefully over these past 4 days, you've heard some projects and maybe have heard a work group that you would like to potentially participate in. So if you are interested, feel free to shoot me an email. I just realized I did not share my name as we got started. My name is Tralisa Hall. I will put my email into the chat box, but you can send me an email and I'd be happy to assist with providing you more information about the coalition and our goals and what we're working towards. All right, so our agenda for today, we have just gone through our introduction. And first, we're going to hear about Texas immunization dates and uses from Dr. Amy Hughes. Following that, we're going to hear from Dr. Philip Massey about moving from observation to intervention in social media research, learnings from project #HPV. I know we had some questions about social media yesterday, so if you have any, this is a great time to hear what Dr. Massey is going to discuss. Following both of those presentations, we will have the open Q&A. So if you have any questions, feel free to jot them down. Use the chat box to engage, but we're going to have open Q&A following both of those presentations, and then we will wrap for today. Again, I want to thank you all for joining. Thank you for hanging in here with us, and I am going to hand the floor over to Dr. Hughes.
Good morning. Let me get my slides up and I'll get started. Sure. Yes. Okay, can you see my slides?
I'm sorry, yes, we can see them.
Okay, so thanks so much for being here this morning to listen to me talk and participate in this work group. My name is Amy Hughes. I'm a geospatial information scientist. I'm an assistant professor at the Department of Population and Data Sciences at UT Southwestern. And my background is not only GIS, but also economics. And I have been studying health behaviors like cancer screening, including cervical cancer screening for quite some time, but HPV vaccination is one of the newer areas that I'm just getting into. So today, I'm going to start talking a little bit about how I got into HPV. It's actually from COVID-19, how I got into kind of this idea using these data that are centralized reported. I'll talk a little bit about InTrack2, which is our system the state uses to keep track of who's immunized. Then I'll go into some use cases for those data, and then talk a little bit about some of the challenges in using these data. So for me particularly, COVID-19 was kind of this introduction to the importance of centralized vaccine registries, particularly in Texas. I'm sure we all don't need to be reminded of what's been happening in the last 2 years, but we did see, oh, did it stop? There we go. We did see we're on our way to a third or fourth hump on this pandemic, depending on who you ask, or fifth. And throughout this pandemic, we did roll out vaccinations unequally. So on the left, that's a histogram of incidents per 100,000. And those blue lines are the vaccine eligibility groups. So we started with healthcare workers and then moved on. And you can see on the right, that's just the spatial distribution countywide of the entire pandemic through, I think, last week. We know that there's a number of things that can cause spread of disease, particularly this disease, and one of those is one of the prohibiting factors would be vaccination. So that's an important, particularly important thing to study and to make sure that there's equitable access. In the United States and many other countries, we know that vaccine rollout was really unequal across different population groups, and that was by design. So we started with those frontline healthcare workers and long-term care facility residents. We knew that those were particularly risky occupations and residential areas to live in. We moved on to people who were 65 or older, or people who had increased risk of severe illness from COVID. And then significantly later, we moved on to schools and licensed childcare personnel. Soon after that, people who were 50 to 64 years of age. Soon after that, everyone was 16 and older. A couple months after that, 12 years and older. And then just recently, everyone 5 years and older. So many of these categories have created unequal distribution of vaccines across certain characteristics of the population. So one of those things is obviously age, because we know that severe illness is related to age, right? But the other thing that's not quite as apparent is that this is also related to SES. So people who have jobs that are high risk or high touch or service industry, those people might be lower SES. And we also know that the way that the vaccine was rolled out in many cases was not person to person because of the way that the virus spreads. It was all touchless. So people had to have a certain amount of internet access or tech savvy in order to kind of navigate their ways through that crazy environment where we were all clamoring to get vaccines. And then they also had to had transportation. So some of those things were very unequal in our distribution. And we wanted to know how do we know if there's pockets of low vaccination that's caused by these structural barriers? And if there were, where should we target the outreach and what form should that outreach take? We wondered these things because in particular, we were worried that if highly vulnerable areas had lower vaccination rates, we could have significant issues later in the pandemic, 2 or 3 weeks, so sometimes after we realized there were low vaccination rates. And those low vaccination rates, if they're concentrated in a specific area, there could be accelerated local community spread, and that would potentially lead to hospital bed shortages locally, which would lead to things like increased mortality, higher prevalence of long COVID, because more people who get COVID, there will be more people who have long COVID. And then also important would be further depletion of our healthcare workforce through burnout and other kinds of issues. So on the right-hand side of this slide, this is a map that I made with some of the data that the state releases at the zip code level for vaccines, COVID vaccination. It is a bivariate map. So anywhere that you see a pinkish hue, a pink or a red hue, that would be a place where the population is vaccinated. So more pink equals more vaccinated. Anywhere that it's more purple versus blue would be a higher measure of the CDC's social vulnerability index, which is a multi-core measure of social vulnerability. So it takes into account many different characteristics or many different drives of vulnerability. And you can see in Texas, we have some interesting patterns. It doesn't necessarily follow that if an area has high SVI, they're also unvaccinated. There's a large swath at the border where there is high SVI, but also high vaccination rates. And then in the cities, we typically have the same pattern that we usually see in geography, which is that the north of a city has good health outcomes and strong relations with providers and access to healthcare. So they have preventive care. And then the south part of a city typically doesn't. So that's what we see across Texas. So a little bit about how we came to this our current centralized vaccination reporting system in Texas. In 2003, it was the first bill that was passed by the 78th legislature. And it stated that providers and payers, so insurance companies too, anybody who administers an immunization to a child less than 18 years old has to provide certain data elements to DSHS, the Department of State Health Services, and those elements have to be submitted in a certain way. So that sets up the basis for this vaccine registry. Parents can grant consent or ask for exclusion when they apply for a birth certificate. In 2003, when this started, that consent was revoked at the age of 18. So once a child turned 18, their data were no longer included in MTRAC. And then when it started, parents could submit immunization history to the system as well. In 2007, there were some changes that the House kind of codified through House Bill 11. That expanded MTRAC to intentional, among other things. There were other things that happened in 2007, but MTRAC was extended to be an intentional use in response to public health emergencies and also to capture adverse vaccine reactions. And then it also, in 2007, expanded to adults for the first time, specifically first responders and their families. In 2009, we permitted adults to consent to participation. And once an adult consents, that consent spans their entire lifetime. Those changes were implemented in 2011 to the actual system. In 2015, we extended the age at which data is removed for young adults. So data is now removed at age 26 if there is not a consent on file for adults. And then the big change, the one that I'll probably be talking about the most in this talk, was that there was new MTRAC functionality, and it actually evolved MTRAC from regular MTRAC to MTRAC 2. It included a number of things, but in particular, there's a bidirectional interface where organizations can pull reports now. They didn't used to be able to do that. And that was implemented in 2017. From our side at UT Southwestern, I think that we really dug into this bidirectional interface and took advantage of those reports once we started having to report for COVID vaccinations in particular. So one of the things that we did, I am part of a prediction group for the pandemic here at UT Southwestern. We are really interested in predicting when there's going to be new peaks in the distribution of cases, and kind of every week giving an update about that and figuring out which populations might have higher prevalence or incidence coming up. One of the things we're really interested, of course, is vaccination. So we did a little bit of an analysis and masking on masking and vaccination using some of the state-released COVID-19 vaccination data, which you saw in that map. As we all know, here in Texas, our governor declared or clarified a ban on mask mandates before the school year, despite us having known that there's Delta circulating in the population, which is highly transmissible and severe. Despite that, some of our school districts implemented a mask mandate anyways for their students and their teachers. So we looked at student, staff, and incidents from August through the end of September, actually October 2nd, but October 2nd is a lot longer than September. We were looking at specifically for our exposure district level masking policies. We combed all of the news reports we could find from August through September to figure out which schools were masking and which ones weren't. And we included correlates, the starts of the school, the week that school started, the weekly vaccination data from the state, rolling average case counts, funding data, and population characteristics. We use propensity score matching to link treated districts with similar controls. We use an event study design centered on school start date. And then we had a two-part estimation strategy, which is that last little line about figuring out which districts were more likely to have cases or not. This is what we found. We found significant differences in student incidents, even after accounting for community vaccination in 3 of the 8 weeks in the first 2 months of school. There were a lot fewer differences in the staff incidents. There's only 1 at week 4. There's a lot of different conclusions we can kind of come towards from these data, but one of them is the idea that vaccination is probably strongly protective in the adult staff population. One of the major differences between these two populations is access to vaccination at this point, because vaccinations for 5 and older were not approved until just recently after this study. Another use, kind of similar to this, another use would be state-released HPV vaccination data. So It's difficult for researchers to get their hands, I believe, on the full MTRAC data set. But I do know that some researchers from MD Anderson worked with the department to report on HPV vaccination back in 2014. And the reason why this stuff is important is that we know there are individual and areal level correlates of HPV vaccination initiation. Those things include gender, age, ethnicity, socioeconomic status, parent educational attainment, and then poverty and education levels of the surrounding neighborhoods. I did not include in here health system or provider factors, which we know are incredibly important when children and parents do interact with the healthcare system. But the reason why is that when I was looking at this list, I have a background in economics and urban economics in particular, and a lot of these correlates are the same list of correlates that we know people sort into. We call it sorting into neighborhoods. So they choose a neighborhood either consciously or unconsciously, depending on attributes of those neighborhoods. And those attributes would be things like income or poverty, race or education, race or ethnicity, education, occupation, age distribution, and housing types. So those two lists of correlates are pretty similar, which means that residents and neighborhoods of counties, they group on the same characteristics that influence HPV vaccination, which means that we can expect significant variation in HPV vaccination uptake. This is an image from that report showing that there is significant geographic variation in HPV vaccination uptake just within the state itself. Surprisingly or unsurprisingly, if we were paying attention to the COVID maps that I showed a couple slides ago, El Paso County had the highest HPV vaccination initiation rate for both males and females compared to the entire rest of the state, including metro areas and other more populated counties. I'm kind of taking a step back from that. If we don't use the state-released HPV vaccination data, there are a couple other sources you can use to characterize geographic distributions of HPV vaccination. One of those would be the Behavioral Risk Factor Surveillance System, BRFIS. That's really great data. We use them all the time for population surveillance. That's what they're for. But one of the drawbacks from a geographic perspective is that the full sample is typically in every county could be representative of the population in that county. But once we start looking at subsamples, it gets a little bit sparse, and it kind of does that pretty quickly. HPV vaccination, we're looking at a specific subsample of age, typically. So that could be a worry if you're using BRFIS data. The other one would be the National Immunization Survey team, NIS team. That's really not big enough for an entire geographic coverage to get different variations across the state. So on the two images on the left, those are published vaccine coverage for the state of Texas, both by Jan Uberth. On the left, ages 11 through 17, in the middle, ages 18 to 26. And there's a little bit of difference in those cutoffs for the colors, but we can see that the darker colors among these two different age groups concentrate in different areas. So the distributions are very different across Texas. On the right, that's one publication using NIS team to characterize HPV vaccination rates across different areas in Texas. And we can see again that El Paso has the highest rates of vaccination, and the rest of Texas, some areas just aren't even close to that. This is a little blurry because I took it from the same report. These are the same data, but for MTRAC data. Same idea, but with MTRAC data. So on the left, we have females age 9 through 18 that started, and on the right, we have females who completed the series. And again, there's significant differences in the geographic distribution of these two behaviors. So initiation is really strong in South Texas, but completion isn't as strong compared to other areas. And this is the same idea, but for males, 9 to 18 years old, left initiation, right completion. And with males, we can see that boys who start the series probably also finish the series because the distributions are pretty similar across the two maps. The third way that we can use these data is a little bit different. It's not a population perspective. So previously we were talking about entire states, the entire state coverage of COVID vaccination and the entire state coverage of HPV vaccination. There's another way we could use these data thanks to the bidirectional interface. Typically, previous health studies of health system research studies rely on EHRs, electronic health records, or surveys to create cohorts. Those both have challenges. EHRs could have incomplete capture of the vaccine data if the patient received a vaccine at a different clinic or system and did not report it or did not have an opportunity to report it to their primary care provider. Hopefully that isn't the case. Hopefully when children go in to see their doctors, their immunization records are being reviewed. But we all know that that might not happen every single time for every single child. And then surveys, those other two ways to talk about population distributions of HPV vaccination, those were surveys. They cost a lot of money. Typically, if there's a survey not administered by a state or a federal entity, they'll be pretty focused on localized populations. And there's always the chance that there's a little bit of response bias. So earlier I said that MTRAC2 is bidirectional, meaning that organizations or payers can pull down data for their own patients or coverees. Previous versions couldn't actually do that. So patients had to report vaccination status. These two blocks of text are from two different studies in 2012 that created cohorts from EHR data and assessed vaccination rates among those cohorts. Both of those quotes say basically, we looked through the EHR for any kinds of records and we accepted self-reported records of HPV vaccination as well. So I've been talking about this bidirectional interface for a little while. You might be wondering, if you don't know, if you're not familiar with it, what kinds of updates are transmitted through that interface. These are from a early version of the implementation guide from quite some time ago from the Department of State Health Services. On the left, there's 3 patients who have vaccination events. They received a vaccine or they reported that they received a vaccine. So the clinic will go through and look at who's got that vaccination data, and then every month or every week or every day, depending on how often they submit, they will create a report and submit it to MTRAC. On the right, that's actually what that report looks like. So we have some lines of text at the top saying, hi, we're reporting. Then there's that first section would be the first patient that I've circled. The next section would be the second patient, and the next section is the third patient. And then at the end, there's a little bit of text saying, okay, we're done now. This is an HL7 message. It's a language specifically designed to query and report health system data. So it actually can be used not only between health systems and the Department of State Health Services, but also among different clinics within the same health system. And it is the industry standard for how we transmit these data. So I said earlier that UT Southwestern, we kind of really dug into this idea of the bidirectional interface. We really wanted to make sure that because of the way that the vaccine was rolled out, early on, organizations who were able to have high throughput for this vaccine, they were able to show that they gave out all the doses that they had requested. Those organizations were able to get more doses more quickly. So it was really important to know that we were submitting all of our records on time and that the state knew that we were doing what we were supposed to be doing. So we wanted more vaccines. And at the beginning, we're vaccinating high risk workers and long-term care facility residents. But the idea was that if we do really, really well from an organizational perspective, if we do really well in distributing that vaccine at the beginning, then later on, when we have vaccine is open for all of our patients. We'll have enough vaccine to really make a difference in our local community and in our service area as well. So we won't be constrained by supply issues. So we really took it among ourselves in the prediction group to make sure that we were pulling down reports to show who got vaccinated and how many were vaccinated and how well that data was being transmitted to the state. And although I don't have a diagram for how we submitted data and got data back, requested data back, I was able to find through the Department of State Health Services website, Blue Cross Blue Shield of Texas does a similar thing, and they did a webinar about it. So this is from that webinar. On the right-hand side, that's a diagram of how Blue Cross Blue Shield submits a query for data and then receives that data. So they have a member roster. They have this availability interface engine where they're submitting their membership roster from there to MTRAC. And remember the HL7 messaging, which looks like this on the right. So they have a query that's built a little bit different. They send it to MTRAC2. MTRAC2 looks for all of the people that are in that query. They send this kind of information back. If they found a member, if not, that returns an error. And then all of that information goes back to Blue Cross Blue Shield. And Blue Cross Blue Shield, or us, when we ask for COVID vaccination, we can pull information, we can report it, we can break down which characteristics of the population are more likely to get vaccinated and which ones aren't, from that kind of information. The reason why this is important, particularly for data or for vaccines that might have significantly higher controversy around them. So HPV is one of those vaccines that it can be difficult to talk about or convince a parent that your young child needs to be vaccinated against the sexually transmitted virus, right? That's one of the issues. For COVID, it was so politicized that there's an issue trying to overcome that barrier that's been thrown up. And a lot of times when we think about these things, we don't just want to work within our own clinics or within our own service areas. A lot of times we would like to kind of seed information through social media if we can, so that when providers have discussions with their patients, they might have a more productive discussion if that patient has more information that maybe they got through social media. So in the middle of this slide, we have what we like to call the onion. Typically, we use this to think about cancer screening, all of the different levels of correlates or influences on cancer screening behaviors. But in the middle, we have patients. Patients, they have their own social support system. That social support system will encourage them or maybe discourage them from screening or vaccination. Everyone is nested inside of a provider team. Maybe not completely nested like it shows in here. Maybe they're unnested on one side, or it might not be as beautiful as this onion is. That provider team operates within inside of a organization or a practice setting, and they have their own rules and regulations and policies that influence the relationship between the organization and the provider, and then the provider and the patients as well. All of those things are nested inside of a community. So a community, they have their own thoughts and feelings and norms and operational procedures, which might influence all of the relationships therein. And then that community environment is nested inside of a policy environment. And that policy environment can require certain behaviors of certain groups of people, which would then affect all of the other relationships inside of that onion. So I was talking earlier about how we might want to use social media to put together a campaign for vaccination. And that campaign might target a couple of things. For example, for COVID or for HPV, it might be misinformation. And it might have the ultimate goal of creating intention to vaccinate, right? We know that people who intend to vaccinate are much more likely to actually get vaccinated. So when organizations put together a social media campaign, they might be trying to influence multiple different levels of correlates that ultimately will influence the patient. They could be influencing the organization and practice setting, they could be influencing the community, they could be influencing the social support system, or they could be influencing a patient themselves. So the idea is that if your organization is putting together a social media campaign and they have information about who on social media is distributing what messages and who interacts with those messages, they might be able to pull MTRAC data sometime after that campaign to figure out who might have gotten vaccinated at other places in relation to that campaign. So from the EHR, we could pull vaccination outcomes because we know that there's a bidirectional interface. We can get information from one health system can ask MTRAC, hey, is this person vaccinated? And MTRAC will return yes or no. So we know that that's has much higher fidelity. We can get patient characteristics, provider characteristics, practice setting policies, those kinds of things, all from the EHR. If we have a social media campaign that's designed with click-through links, you might be able to tell who's actually clicked on what link, which means you can associate the campaign with an actual vaccination episode. And then there's other things we can look at, like internet or cell connectivity from the American Community Survey data or healthcare access. And all of these things could kind of combine to put together a really interesting analysis of a social media campaign. And the reason why I mentioned this specifically is that it should tie into the next presentation quite well. So a little bit of caveats about using these data. We found out, and of course it's this way, you must have a treating relationship to pull those data. Depending on an IRB, you might not be able to do this for research only. You might actually have to do it only in the context of treating an actual patient. We have found out through our many missteps in COVID that sometimes when the records don't successfully submit, we don't really know why there's an error and we can't chase it down. There is a very big handbook on what those error codes are and what they mean. But the people who are actually submitting the data might not really have the time to go chase that down. Another thing that we found out is that there's a deduplication or a matching process when sites or organizations submit information. I'm not really sure what that process looks like. We all know there can be errors in that, so just a warning. And then the last thing is actually from a report stating that the administrative burden for dealing with this type of reporting is fairly high, and the benefit might be relatively low given that the bidirectional interface didn't exist until 4 years ago. So many of the clinics and health systems likely monitor their HPV vaccination or their COVID vaccination with EHR data or other systems themselves. So all of these things might combine to maybe make it a little bit more difficult to interpret the data from NTRAC, but NTRAC has good coverage for children in Texas. It can be used for snapshot analysis quite easily, quite well, and there's really no reason not to think about using them if you can. So at that, I will stop and answer some questions if you have any, or open the floor for conversation.
So in the interest of time, just because, hi everyone, and welcome to Friday. In the interest of time, we're going to go straight into our next, and so please hold your questions towards the Q&A session. And just a bit of a context, right? We've had through our data technology work group a lot of interest in the state immunization registry, and what we've seen over the pandemic is growing recognition of the value and use and some advances. And that's part of the reason why we wanted to make sure that Dr. Hughes was able to update us on how health systems across the state might be using this bidirectional interface to better understand and target, particularly when they were participating as COVID-19 vaccination hubs and really trying to serve the greater community. What are new styles of vaccine delivery have done in opening creativity in how we deliver vaccines is an interesting thing, right? Moving people outside of their regular healthcare system to receive vaccines through vaccination hubs early in the COVID vaccine epidemic, and then how we've reverted back to encourage vaccination by healthcare providers when vaccinating children is a really interesting shift, which has varying implications in terms of how we analyze data. But we wanted to make sure that we illustrated that there is use and value in the bidirectional interface. There's interest in studying this from a multi-level perspective, given what we know about geographic disparities happening in Texas. And I know many of you will raise your hands up high when it talks about the challenges with the HL7 errors, particularly those of you staffing the smaller clinics. So I know Amy can echo your perspectives and the challenges of HL7, but it's an important thing. It is my pleasure to then transition us to the next session with a presentation by Dr. Massey, who is from the University of Arkansas. And part of the reason we wanted to recruit him to come and speak here today is because of his history doing studies in HPV vaccination and health communications via social media. Started this work at UCLA and brought it forward when he was in Philadelphia and Drexel, and received a really interesting R01 called Project Hashtag. And he'll be sharing some data that he's been collecting, both on observational data related to HPV vaccination via social media, and how he's actually turning that into interventions. Philip?
All right, thank you so much. Let's see if I can resume the share. Could you confirm, Tralisa, that you can see my full screen, or is it in the presenter?
Screen.
Okay. It's really an honor to be invited to speak with you all today with the Texas HPV Coalition. And Dr. Hughes, thank you so much for sharing that important insights with us with the data, and Dr. Tiro for inviting me. So I'm going to talk to you a little bit about my work with social media. I am at the University of Arkansas, and I'm in health communication. And a lot of my work is on online, digital, and social media research, and specifically to the HPV vaccine. So I'm going to share with you some learnings from a project that we're working on, and first provide you some background on that project. So the goal of this intervention project is to examine the effects of narrative, right? Narrative focused, storytelling focused scientific information for the HPV vaccine communicated on Twitter. Twitter, of course, is one of many social media platforms, and we can go into more discussion in the Q&A of why Twitter or why some other social media platform. But how did we get here to this intervention work with Twitter and HPV vaccine? Well, there was a first phase starting really in 2015 where we really focused on surveillance or observational work, right? So this is collecting data from social media about the HPV vaccine on various social media platforms, and really characterizing, describing how people are talking about the HPV vaccine, what types of information are being shared, are being liked, really looking at engagement, but really from a surveillance or observational standpoint. That then gave us some insights leading into the creation of a health education and health promotion campaign. Really this content building from that observational work. And then this third phase is evaluating if this approach, thinking about our learnings, thinking about how we developed our health education content. Does it work and with whom? So that phase 3 is where we find ourselves squarely situated currently. So excited to share all of that. I like to start this talk, this presentation with really setting the stage you can agree to disagree, or you can completely agree with me. But I argue that we go to social media to feel something. We go to social media to connect with others, to learn, absolutely, but to learn through connections, to learn through interactions. And health content, health education materials, when we leverage this idea of we go to feel and hear and listen to each other, stories told through social media could be powerful tools to promote health. So I want to sort of lay that as the foundation for this talk. So back in 2015, we looked at Twitter related to the HPV vaccine hashtag HPV vaccine, hashtag Gardasil, hashtag Cervarix at the time, a few other different hashtags. And we collected almost about 200,000 tweets over about a year's time, August 2014 to 2015. And we did some content analysis and classification analysis, looking at, is the communication on Twitter positive? Is the sentiment positive? Is it negative? Is it neutral, right? Is it very information focused? Does it even mention the vaccine? Another piece we looked at, we looked at many other pieces, but two other pieces we looked at that I'll talk to you about now is who's sending, or who is the user of the information, right? So we analyzed for, was it a health professional that was sending it, a parent, who was the audience for that, really starting to segment some of those audiences. And then we began thinking about what type of information was being shared, right? You have the sentiment, but was it resource information? Was it very sort of matter of fact information based? Or were these personal stories or experiences? So that's what this figure drills down to. Was we saw in our observational work that when resources and information were being shared, right? About half of the tweets, 50% were information resources, just over half. In large part, these were us, right? These were health professionals who are really great at sharing information and resources. I think we're really good at that. One thing that we found that parents were more tuned into were these ideas of personal experiences. So really talking about the HPV vaccine from their child's perspective, or their family perspective. And we know that health professionals are a very strong indicator, right? Having a recommendation from a healthcare professional is a very strong predictor of a parent getting a vaccine. So deciding to get the HPV vaccine for their child. So we started to think, is there a way we can better merge these two things, right? Where healthcare professionals, because parents are talking about personal experiences, they certainly need and want health information and resources. Is there a way we can deliver health educational material, maybe told through more experience and storytelling? This was on Twitter. I want to take us over to another platform, Instagram. We also looked at the HPV vaccine communication on Instagram. This is a little more recent data in 2018. But we found, again, thinking about this informational posts and storytelling narrative posts, we found that informational posts on Instagram related to HPV vaccine were more prevalent, right? 65% of them were information, fewer were narrative or storytelling. We then kind of looked at it through the lens of pro-vaccine, pro-sentiment towards the HPV vaccine, and anti or negative sentiment. And that's where we begin to see a difference in this information, prevalent informational sources and narrative informational sources, where informational sources were in large part more focused on being pro and positive vaccine, right? That's 60.9 compared to 39.1, right? So informational sources were more pro. Hey, guess what? There's still a lot of informational sources that are anti-vaccine. Great use of misinformation out there. When we looked at narrative, this flipped, right? The narrative, the personal experiences were much more anti or negative HPV vaccine. So again, we started thinking, is there a space for us to be in this personal story narrative space to really lift up positive emotion as more negative is prevalent? That's the observational work. And again, metadata, or these likes, reposts. Look, we've all been on social media. How many of us have liked something? How many of us have reshared or posted something? Guess what? The social media platforms collect all of that information. And then in turn, researchers or more importantly for social media, marketers and companies who pay them a lot of money for that information. We looked at personal narrative and information sources, and the mean like count was much higher for the narratives. This is saying that people were engaging or interacting more, clicking that button for these personal narratives. And again, the personal narratives were more times than not anti-vax. So this is sort of the story that sets us up for the intervention or the work that we propose. So we put forward the central hypothesis that that narrative engagement, right? This is drawing from narrative engagement theory, that when people can identify with information, with stories, when people can empathize, when people can feel transported into a story, that message, that material is much stickier. And we are hypothesizing or arguing that based on narrative and non-narrative messages, right? Those narrative ones are story first, non-narrative are information first, would then lead to different engagement from parents with that content. And then in turn, because the message would be stickier, because parents may be able to grapple with different questions or decisions in that story-focused educational material, they may then change their intention to vaccinate and ultimately vaccinate their kid against the HPV vaccine. So this is our central hypothesis and how we began, right? We did a lot of observational work. Well, we needed to start with the community. So we recruited parents from Twitter and developed a parent advisory board to help us sift through all of this information, get through the research process. We have a 6-member parent advisory board, diversity and geography. Hey, we have a Texan in there, vaccination experience, race, ethnicity. So we have parents who represent diversity in multiple areas, and we're going to continue to grow this parent advisory board. But they're critical in helping us sift through some of the content. We also conducted virtual chat-based focus groups, 6 focus groups with 48 parents. This was at the height, we're still in this pandemic. This was in the height of the pandemic, so the virtual chat-based worked well. But some key themes from those focus groups that emerged was, I love this quote that I have, or this cross-cutting theme, is that parents want to hear stories about the HPV vaccine, and particularly pro-vaccine stories, but they're not that common and they don't really know where to go to get them, right? So again, this sort of contributed to our idea of being in this space where people talk about stories, talk about feelings, talk about experiences. But what was critical when we're talking about a university or a healthcare group or a health system, relaying this information, information being verifiable, even though it's told through experience and story, showing authenticity and credibility from the channel, right? The source who's providing this, having a mix of evidence and narratives, describing more positive experiences, and really describing how or what discussions with healthcare providers and other parents may look like, right? That's that role modeling piece. So taken together, right? We have our parent focus groups, we have our social media data, we have our parent advisory board. Dr. Hughes mentioned the NIS teen survey that documents a lot of struggles or hesitations with the HPV vaccine. These various data sources, right? Talk about mixed methods data. These various data sources were used to inform personas. And these personas were going to be the driving mechanisms for delivering this information, this story-based information. So we're not taking actual parents and having them talk about their stories, but we're developing personas of types of parents, drawing from actual parents' stories and experiences and creating this content. So this is a nifty diagram that one of my doctoral students put together. This is far niftier than I could have ever done, but showing sort of the process of walking through how we collected the data, how we refined it, and how we're developing our messages. And this is, I provide a reference for this too at the bottom. But what was really nice is we were very clear where each of these data sources were used to draw out these personas we're developing. So for instance, from our social media data, we found that informational resources were a foundation, right? It was very important. We also found that there was a lot of conspiracy theories or lies, right? So that needed to be sort of dealt with through some persona. Misinformation at times difficult to decipher or address. Again, that had to be addressed from a persona. And then personal stories were really engaging. So as we started to sift through these different data sources, cutting across these personas began to emerge. The informed altruist, the real talker, the information gatherer, and the supporter. Really a robust field in marketing and branding, thinking about how we can develop personas to communicate about products. We went deeper into this with potential demographics, but also psychographics, right? So thinking about what motivates these different personas. Again, we had our parent advisory board constantly refining, thinking about how we can better create these personas and thinking about challenges and frustrations. You know, the informed altruist. This is someone who is pro-social motivation, really non-confrontational, really great in group interactions. And they sometimes struggle to voice their own questions or concerns because other parents look up to them as the expert or the go-to resource, right? Hey, in academia, raise your hand if you've never had that imposter syndrome, right? The real talker, right? They are the myth buster. They are really comfortable with more confrontation. They get frustrated by vaccine myths, inaccurate information, etc. I'm detailing this, and I know I want to be able to get through this so we have plenty of opportunity to discuss. And this is detailed in that one of the papers that I have in this presentation. But this is the level of detail we went into. Thinking about these parents, really giving them a backstory so that we could come up with characters, right? So the informed altruist transformed into Lynn, and Lynn is a nurse at a hospital, and she's really able to be that solid beacon of information in the group. Dana is the real talker, and she's, again, really grassroots motivated and really comfortable with that confrontational, not in a negative way, but just sort of as all of us have that friend or family member online where we just need to have them call them out once in a while for talking about or spreading whatever we don't necessarily think is true. The information gatherer, right? Jessica is this person who is a bit on the fence and just needs to know more information, right? Research, do your research. That was a constant theme we heard in our focus groups and with parents, is that parents, they're not afraid to do their research, right? We want to do our research. We want to Google. We want to look at blogs. We're not afraid of getting our hands dirty. And then the supporter turned out to be Miguel, who's a grandfather, right? So this was able to bring in a father figure, a man into the conversation, and also just the importance of intergenerational support with the HPV vaccine. So that's our content. That's our characters that are going to be delivering this content. And now this is how we're going to be testing that content. So in AIM 1 of our study, we developed and refined all of these narrative focused messages. In AIM 2, where we currently are, we are recruiting parents into our study. We're randomizing them to narrative or non-narrative arm. We're asking them when their kids' next annual well care visit is. So say, you know, you're on Twitter today or you're on Facebook and you see our recruitment ad and you click on it and you fill out the eligibility screener. We say, you know, do you have a kid between the ages of 9 to 14? Have they gotten their HPV vaccine? And when is their next scheduled well care visit? So if you have a kid and they haven't gotten their HPV vaccine yet, and you say the next well care visit is scheduled for May, right, at the end of the school year, then you're going to be participating in our study a month before that May visit. right? You're going to be participating in April. You're not going to be participating tomorrow or next month. We really focused on the month prior to the doctor's visit to be able to deliver this information so that parents, when they go to that doctor's visit, are a lot more likely to be primed and remember that information. So we have various staggered cohorts going on throughout the year. We follow up with a follow-up and a one-year follow-up to say, did you vaccinate your kid immediately after, and then the 1 year, 6 month to 1 year, asking about their second dose. We also have this neat piece, AIM-3, that's this observational piece where we're asking for the parents enrolled in our study, we want to collect their Twitter data, how they're tweeting, what they're interacting with 1 month prior, during, and 1 month post our campaign. And this is really just trying to help contextualize our intervention, right? So we're not expecting parents to necessarily tweet about the HPV vaccine 1 month prior or during, but maybe they tweet or share a post after, right? That's a really important outcome for our study. Do they talk about with others about the HPV vaccine? So this is not necessarily in our closed group Twitter campaign, but we're sort of helping to contextualize or understand some of the larger social media environment that is potentially facilitating or not the intervention effect. So we're actively recruiting. These are some of our recruitment ads. We're recruiting on Twitter and Facebook, also using our community advisory board networks. Recruitment. I gotta say, anyone who's ever done a study knows that recruitment is critical. We're delivering this content through 8 chapters. These are some key topics and themes that our advisory board and our focus groups wanted to make sure we covered. So in both the narrative and non-narrative arms, we're making sure we touch on each of these topics. There's no really additional information provided in one arm or the other. It's just the way that that information is told or provided, right? So for instance, some of the non-narrative tweets, we have some great examples. ACS has some great examples. CDC, HHS, just some great examples of what we're calling non-narrative tweets, just sort of informational posts that are clear. And these are what our parents are going to be getting in the non-narrative arm. And this is just a screenshot, an example of what parents in the narrative arm would be getting. So seeing how Dana and Miguel, Lynn and Jessica are talking about issues. This is an example of the chapter about HPV vaccine equity. So Dana, talks about how sometimes she gets pushback from her kids from her previous pediatrician because she would ask questions, right? And Miguel talks about how Spanish is his first language, and it's also sometimes difficult for him to speak up and voice his opinion. And they talk a little bit about some of the epidemiology of the HPV virus and cervical cancer in both Latinx, Hispanic communities and Black communities. Lynn brings in some solid information in there, and Jessica, appreciates that or is sorry to hear that there's a need for this, but really understanding or trying to understand that different communities have different barriers. So this is sort of the vibe that the narrative content has. Here's another one that's focused on vaccine safety. One of those other chapters was vaccine safety. So the non-narrative arm would be getting some really solid tweets about how safe the HPV vaccine is. The narrative arm, Dana starts out by one of her Facebook friends insisting that it's not safe to get the HPV vaccine. And they sort of go through that topic with each other to suss through it. So going back to our key conceptual model, this narrative engagement piece, right? We're asking parents in both arms. Both arms have content that has parents in them, have children in them, have words, have content. So we're really tapping into comparing those two arms, asking parents, did the emotions portrayed in the post, did they find them to be genuine? Could they understand the information in the post? Could they relate to the information? This definitely will make sense in the narrative, and it will also in the non-narrative. We create informational posts, hopefully so that the information makes sense, hopefully so that they could relate to it. So we're really asking and anticipating that in our narrative arm, these scores will be much higher and will then contribute to higher intentions to vaccinate just immediately pre and then immediately post higher self-reported vaccine rates. This study is ongoing, and it's not without its many limitations or implementation considerations. So we're thinking a lot about content delivery, right? We're recruiting parents, we're enrolling them, we're having them in enclosed Twitter groups, but we're thinking about how we can maximize the likelihood of our tweet content showing up in their thread, right? We're not putting them in an artificial environment where we know that they're seeing it, but we're really trying to see how can we understand if the content shows up in their thread. How can we measure the exposure of the content, right? So asking them self-reported if they saw it, of course, that's a great way. Measuring if they click on it, viewing some of the Twitter analytics, the impressions, that's another great way. Study recruitment, you need to be nimble in this type of work. Adapt recruitment strategies. Our IRB has been really great, and we've worked very closely with them, understanding that social media research, we learn sometimes, we put our best foot forward, but sometimes, hey, just like in any community outreach, right? We learn along the way, and we need to be nimble. Then thinking about this participant verification, right? So the other day we had an account that we found out that 30 accounts were created by probably the same person, and there was some potential for bot activity. So just knowing how, we're not interacting with these parents face to face, we're recruiting on social media. So just understanding how we can recruit and how we can enroll and verify that participant information takes a little bit of thought. So I'm going to wrap it up there. With those considerations, and thank you for your time. Again, I'm at the College of Education and Health Professions at the University of Arkansas, and there's my email address. And I see Dr. Tiro's back on the Zoom, so I'm going to stop sharing.
So we have about 21 minutes to engage in questions for both of our speakers, Dr. Hughes and Dr. Massey. And if you don't mind, I might take the privilege of asking the first question to Dr. Massey. In terms of recruiting your research participants exposed to this intervention, are you explaining up front that these personas are fake, or how have you tread that line in terms of kind of people's, there's a lot of issues in social media now in terms of motivations of the people who are presenting and whether they are paid sponsors or not, and the like. And so I'm kind of curious how you walk that line in terms of your presentation at the beginning of the invitation.
That's a great question. And I just presented another talk on ethics in social media research, and transparency is very important. So when parents are enrolling, right, and eligible and being randomized, we tell them that they're part of a study at the University of Arkansas and that we're delivering content that's been developed through health education materials. That we're sort of the tent that these conversations are happening in, and these conversations have been created from meeting with various parents across the world, right, the country. So it's clear that these are not real people and real parents, but these are sort of ways for we understand, we're sort of laying out, we understand these are the way people talk and some strategies and concerns they have. So here's sort of our best effort of meeting you where you are. But very important to be transparent and to be on social media, it's because we go to feel, right? Because sometimes we're very emotion forward, right? It can be easy for us to be manipulated and at times coerced on social media. So great question.
And then just to be clear, in presenting the chapters, if people want to engage by posting something on top of it, are you planning on having a response by the personas, or it not having that type of?
We're not having that. That's a really good, that's really interactive and a really great idea. But because we have to draw the line somewhere, right? So we've turned off comments. Parents are not allowed to comment on the posts. We've turned off, we're not interacting with the parents, right? So they're just sort of passively engaging with the content. We are allowing them to like the content, and we're taking off the retweet as well. So it's a balance between putting it in the real environment and then putting it in a very controlled environment. We're finding that balance as we're moving forward, to be honest.
You're the only one I've found so far kind of struggling with these really hard questions. So, no worries about being, the canary in the coal mine in part. And I don't want to take all the opportunity to ask all the questions. I was wondering if anyone else had any questions. Raise your hand or type something in the chat. I might switch over and sorry. So there's a question about from UT and Barnard, is Instagram a possible venue for doing interventions?
Yeah, not only possible, but it definitely should be a venue. There's, with social media platforms, every platform is different. So from a delivery perspective, from a what data you can have access to perspective, but Instagram is where many people are. So yes, it should be. Now, should the content or delivery be the same? Maybe, probably not, right? So I encourage you, if you're interested, definitely think about Instagram as a way to deliver, right? We've done some observational work with Instagram, but not yet thinking about it as a delivery tool.
Dr. Massey, I have one question. Like, how are you measuring the impact of this narrative or the parents' contribution in actual, in terms of reach to the population?
So we're really focused on, there's a great robust literature on entertainment education, and that entertaining first and following with education is really impactful. That really hasn't been done in the social media context. So we're limiting our ability to generalize right now, because we want to really focus in on, is this narrative approach even feasible or efficacious in a very controlled environment. So we're asking our 600 parents, 300 in each arm, how engaged they were with whatever arm of content they were in. But in terms of the larger generalizability, that's not where we are right now with this project.
Okay.
I'm wondering if I also want to loop in and draw together kind of both of your perspectives in terms of, let's fast forward, right? And let's see maybe if my fast forward question makes sense. Let's say, Dr. Massey, that your intervention is efficacious in your research trial, right? And you want to do a more wide scale, implementation effectiveness trial, or just kind of start to release it and see what happens in Twitter. Dr. Hughes, what do you think we should be thinking about in terms of the analysis of that distribution geographically, given the geospatial limitations of Twitter in terms of geotagging that maybe people know or are less aware of, in terms of understanding reach and potential reverb that might be happening in the release? I'd be curious kind of both of your perspectives on that, right? When we get into a real world setting of releasing social media interventions, what should we be worried about, or what should we be monitoring?
I think one of the most interesting things from a regional or a geographic perspective is that we know knowledge, beliefs, and attitudes as far as relating to chronic diseases and health screening or health behaviors, they differ widely among regions, and even within regions among MSAs, and even within MSAs among those representative counties and census tracts. So, Dr. Massey's work is, really, really interesting, and I think could be very effective in changing a lot of those thoughts, feelings, knowledge, attitudes, beliefs, which we know are so important in kind of prompting people to do these preventive health behaviors. But from a Twitter and a Facebook and an Instagram perspective, the obviously the biggest drawback of being able to kind of monitor responses to these interventions is that there aren't a lot of highly sensitive measures, geographic measures attached to tweets, for example. But you might be able to do things like looking at responses in different MSAs, and that I think alone would be interesting, right? We know that Dallas is a lot different than Houston, is a lot different than Austin, and it would be really interesting to see how people interact with this type of intervention based on where they are. And if retweeting is available in the future, who might retweet it in the community, who might choose to let it pass by, those kinds of things. I think that's incredibly interesting and would be valuable to know those types of things about these social media interventions.
Dr. Massey?
Yeah, I think the next phase of implementation is I love that we're fast forwarding, and I agree that'll be wonderful to have positive outcomes, but how to package this, right? There's a whole science out there called how to implement these things, whether it's widespread population level, whether it's packaging for health systems or healthcare groups and providers to be able to have this as, you're sitting in the waiting room and you have some marketing materials that say, follow this account. So I think there's a lot of different opportunities for the geography piece. Yeah, it is very hard I know there's been many papers out there, or a few focused on linking or showing the association between HPV vaccine rates, vaccine uptake with sentiment of HPV vaccine on Twitter, for instance. And I think it's very tough to make those connections. There's just a lot of assumptions and inferences that are challenging. One of the participants mentioned Instagram earlier in the chat. And going back to my point that every platform is different, the culture of Twitter is not very geolocated, right? We're not geotagging our tweets. Maybe 1% or 0.5% are geotagged. Instagram, on the other hand, for those of you who do Instagram, there's much a bigger culture of geotagging, right? So maybe in HPV vaccine world, that doesn't make sense. Maybe in tobacco marketing and products and vaping, it makes more sense when people are tagging where they're purchasing products. So I think there's just a lot of nuance with the platforms.
I think for me, one of the really interesting fast forwarding scenarios would be integration of, hey, follow these accounts online through something like MyChart. If people are really active in using MyChart on their iPhones, hey, get more information, follow us here, follow the conversation, that could be really interesting. But I think there's also a lot of barriers to making that happen.
So someone mentioned Twilio. I'm so not savvy on social media, and I don't know if either of you are aware of Twilio and kind of its advantages and disadvantages relative to other ones. But I think more broadly, the challenges of social media and opportunities, right? In that the COVID pandemic has shown us that we really want to fast forward into an electronic internet-based connection, and how that can further create divides from a disparities angle, right? In terms of what we saw, and Dr. Hughes, you mentioned this at the beginning in terms of who had access to the COVID vaccine, in terms of putting in a request for an appointment, and how the internet-based appointment making process that many did created those type of disparities for our communities, particular urban and rural communities that don't have that internet access or don't have that facilness on the internet and via social media. You know, I am not as familiar in terms of, you know, who are we reaching via social media? Who might we be leaving behind? And you know, I know this is rapidly evolving, but you know, what we should be thinking about it from a disparities perspective and an health equity of distribution of interventions perspective.
I'll start. It's very challenging. And I think first off and foremost, social media is not the magic bullet for anything, right? It is a set of tools, right? That's all it is. It's not necessarily innovative in and of themselves. It's how you use those tools to be able to reach different populations. But it is one strategy of many that need to be applied. And I do think we run the risk, if we put more emphasis on digital strategies, I think your COVID vaccine example is a perfect example of how many of us, you know, helped parents or helped grandparents log on to the sites to get them a vaccine, and not everybody has that ability. I will say the demographic of users continues to shift constantly. So being nimble, you know, Facebook in 2006 and 2007, it does not look like the users of Facebook now in 2021. So just being able to understand and shift that. Also thinking about rural and urban communities, right? Or non-metro communities, thinking about the platforms where social media platforms such as, or digital platforms such as Facebook or Nextdoor, right, could be important communication tools. So it's a great question.
Yeah, I think for me, social media is just kind of an indication that, you know, if there is a system where human beings can be social and talk to each other, then they're going to continue to do that, right? They're going to find a way to be reaching out and be connected. And the specific mediums through which we do that reaching out and connection might change as we move forward, right? It always changes with the apps and the technology evolving. But I think that this idea that we'll always have some digital way to interact with somebody, to interact with populations, I think that's sticking around. So, you know, 20 years from now, are we going to have Twitter? Who knows? But we might have something else replacing it. And so it's really important to understand, like Dr. Massey said, how these systems and how these methods for reaching out to people evolve, and who's actually on the platforms as time goes on. You know, that these tools aren't going to go away, they're just going to change a little bit, right? I think in relation to, you know, this example of the COVID vaccination rollout, for me, it was really interesting thinking or comparing about how we rolled out COVID vaccinations to how inequities in access to other vaccinations kind of appear, right? So we knew a priori rolling out COVID vaccinations that not everyone was going to have access. We specifically created a system where we knew that there were going to be certain subsets of the population that do not have access immediately to those vaccines. And so it was a little bit easier to turn that on the other side, on the analytics side, and say, let's look for populations where we're pretty sure that they're not going to have access. And from a geographic perspective, it was kind of easier to see those results or expect those kinds of results, right? But from, for example, an HPV vaccination perspective, we didn't have that same idea that that we were creating a system that was inherently inequitable. And so it's a little bit harder to figure out what are the correlates of access, right?
Absolutely. Earlier this week, we've had some really great talks about how school health nurses and school systems are involved in HPV vaccine delivery and promotion, and can be key partners with health systems and parents. And I'm curious as to what your thoughts are, given the context that we live in of social media and other issues that are fraught related to schools, things that we should be thinking about when partnering with schools, given vaccination has become a more challenging area to promote from a public health evidence perspective. Should schools, I mean, how would you encourage schools to get involved in this and deal with what might be some political fallout?
You're just bringing the good questions today. Well, I'm coming at it from a social media angle, right? So we know that students are on social media. So is there a way for a school or school system to be a part of that conversation? I think so. Is it a way for maybe as different states allow for different aged youth or young people to decide whether or not they want to get the HPV vaccine? I think that's a neat space to be in. So, I'm targeting or prioritizing parents in my work, but if children had an opportunity later on in high school to catch up, right, it could be an interesting space.
I think this question is much better much better answered by people who have training in behavioral sciences. I'm a geospatial information scientist, and I tend to leave those kinds of questions to people who have training in them. But from my perspective, my own personal experiences would be, if we're reaching out to children on social media, we need to be careful that we protect them.
Yeah, I totally hear you. I know we only have a few more minutes, and I'm really curious what various people's perspectives are. One of the areas that I'm really interested in is what we should be doing via promotion for our young adult population, so ages 18 and older, because Texas has lagged behind other states in terms of uptake of adolescent vaccine. We are graduating large populations of young adults who are unvaccinated but still have access through various programs to get catch-up vaccination, and obviously might be the ideal demographic also to do some of this social media intervention work, as well as to better monitor kind of their uptake when they can decide for themselves in the state of Texas to get the vaccine. And I'm curious as to interest that both of you might have in terms of this issue of young adult vaccine promotion and monitoring of uptake.
I'd be curious what would be the thing that the 18 to 26-year-olds need, right? I would imagine it could be an awareness thing, right? That's kind of one of the simpler pieces. Are they even aware that this is an option? So, hey, blasting a paid ad from Twitter, from Facebook, just to say, did you know, right? You can protect yourself as you go into the next phase of life, where paid ads are easy. You don't need to have a whole intervention involved. But if there's different motivations, if there's attitudinal norm change that needs to happen, it should be a little more involved. But I would say paid ads and target those young people.
Yeah, I would also say that, there's a lot of life changes that happen between 18 and 26. Many people are graduating from high school and going on to work or going on to college, or graduating from college and then going on to careers. And, I think that those changes provide a lot of opportunities for intervention, for providing that kind of information to those 18 to 26-year-olds, right? And so any kind of interaction we can get through those life changes on social media would be great.
Okay, I'm turning it over to Tralisa because we're at the hour for wrap up.
Yes, we are. Thank you all. Thank you, Dr. Hughes and Dr. Massey, for your great presentations today. They were absolutely wonderful. And I want to take a moment, because we are actually at the hour, to remind everyone to complete the post-session survey. I will send another wrap-up email with the slides for today and another survey that will wrap up the entire summit. So if you would please be sure to complete both of those. Also, again, I just want to give thanks to all of our coalition members, to all of our work group leads, to each of our speakers for each day of this summit, and then for each of you for participating and engaging and joining over the past 4 days. We've truly had a lot of great information. We've been able to take in a lot, and I'm really, really excited about where HPV vaccination is going and all of the different realms and avenues that we're working to get this shot in arms. So thank you all for your work. Thank you for your presence. Thank you for, again, your engagement. And we will hopefully see you all soon as the HPV Coalition, like I said, hits the ground running in 2022. So look forward to hearing more from us, seeing us. And if you want to participate, you want to join the coalition, again, send me an email. I'd be happy to add you to our roster and figure out exactly where you want to fit in. So thank you again. Enjoy your weekend. Happy holidays. And we'll see you soon. Bye, everyone.